Thank you for joining us today for this briefing, Obesity in America, Prevention, Coverage, and Impact on National Security. My name is Robert Lash, and I'm the Chief Medical Officer at the Endocrine Society, and I'll be your moderator for today's briefing. Today's briefing has been organized by the Endocrine Society, the world's oldest, largest, and most active organization dedicated to understanding hormone systems and the care of patients with endocrine diseases and disorders. Our membership includes over 18,000 clinicians and researchers around the world, many of whom are experts in obesity and who are making significant contributions to the advancement of knowledge in obesity research, prevention, and treatment. Before I introduce our panelists for today's briefing, I wanted to share with you briefly some important information that I hope will help frame our discussion. The prevalence of obesity across our country is alarming. Over 42% of all US adults and over 19% of all US children are estimated to have obesity. These numbers are even more disturbing when broken down by race and ethnicity. About half of African Americans, 49% of American Indian and Alaskan Natives, and about 45% of Hispanics also have obesity. In addition to compromising many people's lives, the obesity epidemic has impacted our nation's military readiness and national security. Recent data released by the CDC highlights how much obesity has impacted even military recruitment. Just over 1 in 3 young adults between the ages of 17 and 24 are now too heavy to even enlist in our military. Among young adults who meet weight requirements, only 3 out of 4 have physical activity levels that have prepared them adequately for basic training. Consequently, this means that only 2 of every 5 young adults who want to serve in our country are weight eligible and adequately active to serve. Today, we want to provide you with an overview of what obesity is, talk about the complications from obesity, and discuss how it can be treated. We'll also discuss the impact obesity has on our military, our economy, and our healthcare system. Finally, we hope to address policy solutions to address this crisis. It is now my pleasure to introduce our 2 panelists for today's briefing. Our first speaker will be Dr. Amy Rothberg. Dr. Rothberg is a professor of medicine in the Division of Metabolism, Endocrinology, and Diabetes, and a professor of nutritional sciences at the University of Michigan. She's also a member of the Endocrine Society. Dr. Rothberg is a physician and has a PhD in economics. She's also the founder and director of the University of Michigan's Weight Management Program, a lifestyle program for people with moderate to severe obesity. Dr. Rothberg's interests and research program include studies on the clinical outcomes, costs, and cost-effectiveness of targeted interventions for people with obesity. Our second panelist is Dr. Ricardo Correa. Dr. Correa is a board-certified endocrinologist and currently serves as the Endocrinology Fellowship Director and is Assistant Professor of Medicine at the University of Arizona College of Medicine in Phoenix. Dr. Correa pursued his clinical and research fellowship in endocrinology, diabetes, and metabolism with a special focus on neuroendocrine research when he is at the NIH. He is an Endocrine Society member and is also a member of the U.S. Army Reserves and will provide his perspective on the impacts obesity has on our military readiness. We've reserved times at the end of our briefing for a Q&A session. We hope you'll submit questions through the Q&A function throughout the presentation, and I'll be selecting questions for our Q&A session after we've completed our discussion. Please let us know who you are and your congressional office or organization when you type in your question. And also note, all attendees have been put on mute to control the sound quality of our speakers and that the chat function has been disabled. I'll now turn our presentation over to Dr. Rothberg. Thank you, Dr. Rothberg.
Thank you, Dr. Lash, and I thank all of the participants for joining us this afternoon. So first, how do we define obesity? Well, it is excess body fat or abnormal fat accumulation that poses a risk to health. But obesity is often mischaracterized as a lifestyle choice, but it's a complex disease resulting from genetic and environmental interactions. Next slide, please. Obesity is associated with a multitude of complications. In fact, obesity is associated with over 230 complications, not least of which is diabetes, cardiovascular disease, and many cancers. Next slide, please. And as Dr. Lash already alluded to, the rates of obesity are rising. The number of states with high rates of obesity doubled in the past year, according to the CDC. Adult obesity rates have increased 37% in the last 20 years. In fact, rates of severe obesity have dramatically risen and now are over 9% of the adult population. That's 1 in 11 adults. These are indeed the people for whom I care. So these are individuals with BMIs of 40 or greater. That translates, for example, to a woman who's 5'6" tall and weighs 250 pounds. And as you've already heard, the youth obesity rates have skyrocketed and increased 42% since 2000. Next slide, please. And the economic costs related to obesity are absolutely staggering. The percentage of health expenditures related to obesity grew. 5.5% of GDP was due to obesity-related healthcare expenditures. That's little less than $1 trillion in 2014. By 2018, it was 6.75% of GDP, or a little less than $1.4 trillion. Obesity accounts for $170 billion in higher medical costs each year. Annual nationwide productivity costs of obesity-related absenteeism range between $3.4 and $6.4 billion. And the cost to Medicare and Medicaid are $92 billion per year. Next slide, please. But there are effective treatments for obesity. It can be treated, but it requires a comprehensive approach, including some of the strategies listed below, including intensive behavioral therapy, which promotes weight loss through a program of structured diet and exercise, and is recommended and endorsed by the U.S. Preventative Services Task Force. Medical nutrition therapy, which is nutrition-based treatments provided by a registered dietitian or nutritionist, and anti-obesity medications that are scientifically proven therapies approved by the FDA. But there are barriers to treatment. IBT coverage is limited in Medicare, and only 2% of Medicare beneficiaries with obesity receive IBT for obesity. Medicare doesn't cover outpatient medical nutrition therapy for obesity, and there's a Medicare prohibition on anti-obesity medication.
Thank you so much. And now let's talk a little bit about how obesity impairs military readiness. And here I will show you some data that is reported nationally. But I will tell you that as a surgeon battalion for the 492 Civil Affairs Unit in Arizona, I see very similar numbers. So there is an increase of the prevalence of obesity, not only in the general population, but also in the militaries. 19% of our active duty have obesity reported in 2020. And this is an increase of 3% from the prior year. In the reserve, we can see the percentage between 25 and 27%. Impact is also in recruitment. So as we know, obesity is one of the top 5 things that are being reported why their applicants cannot enter to the military. So Army fell 25%. This is approximately 15,000 soldiers in the goals for 2022. 2 out of 5 young adults are weight eligible. So this means that 3 out of 5, they are not eligible to serve in the military. And 77% of young kids between 17 and 24 years old are ineligible to serve. So this is a big problem that we have. Next slide, please. And when Dr. Rothberg was talking about the cost of the medications, it's very important because we are talking about soldiers that most likely they are just finishing high school or in the middle of college, and they don't have good insurance to cover. As we see in this graph, 68% of the obesity medications that we have are out of pocket, paid out of pocket. And the rest is paid with private insurance, Medicaid, Medicare, and really when we see others is where TRICARE, that is the main insurance for the military forces, is covered. So it's also a problem on equity regarding our military. Next slide. And we talk about more about how much money the DoD spend on obesity and its complication is approximately $1.5 billion on healthcare cost, and 658,000 lost work days per year are due to obesity. TRICARE, as I mentioned, is very limited in the coverage. These are the soldiers that protect our country, that want to serve our country. And whenever a problems like obesity comes, they are limited in coverage. The TRICARE only covers certain surgeries, bariatric surgery in certain conditions. And you can see that in the webpage of TRICARE, and really minimal coverage of medical management of obesity. Next slide. Additionally to the military forces, we also have to reinforce that there is a disproportionate impact on obesity in people of color. As you can see in this graph, approximately 50% of Black African American in this country, also American Indians or Alaska Native, and approximately 45% of Hispanic population suffer from obesity. So we are seeing a disease that, yes, is affecting the entire US population, but with affecting more the underrepresented minorities. And next slide. And definitely this doesn't start when you're an adult. This problems start when you're in your younger age. We can see how much is affecting our youth. If we compare Black and Latinos, they have higher rate of obesity than white and Asian Americans. The obesity prevalence in Black and Mexican Americans double in the last 25 years. And it's not only the prevalence of obesity, but the prevalence of severe obesity in youth has increased approximately 6 to 9% in the last 25 years. Children in households with lower incomes have higher rate of obesity, and 26% of children living in households with an income of 130% below the poverty line are obese. So we know that there is a problem, including social determinant of health in this with this disease.
I wanted to thank you both for your presentations. I'm now going to ask Dr. Rothberg to turn her camera back on, and we'll begin our panel discussion. There you are. Great. As a reminder, please feel free to submit questions through the Q&A function. We already have some really good ones I'm looking forward to asking our panelists about. I'm going to start with Dr. Correa. You bring a unique perspective on the issue, given that you're an endocrinologist and a member of the U.S. Army Reserves. Can you share your thoughts on what you've seen on a personal level regarding the impact of obesity on your military service?
Thank you so much, Dr. Lash, for that question. And I think that this is key. What I'm seeing in my unit that is a small compared with all the units that represent in the country is that the increase of obesity in the soldier has going exponentially up in the last 2 years, in between 2020 and 2022. Probably one of the reasons was the pandemic. But important is that every time that I address this issue with the soldier and try to guide them on how to get counseling on behavioral therapy or try to get them to start taking some medications, majority of them, what they tell me is that, I don't have insurance outside TRICARE. Some of them don't have insurance at all, not even TRICARE. You have to think that these soldiers, when they're specialists private, they earn I'm talking about the reserve, they earn $75 to $100 per drill. And with that, they cannot cover an insurance. So every time I try to address that to them, they say, yes, I would love to try that, but I cannot afford it. And then this is a big problem. I feel devastated every time that they tell me that, because these are the soldiers that will be in the front line if something happened. These are the soldiers that are going to places where there is some damage in the US and outside the US, and they are not fit for doing that. It's not because they don't want it, it's because there's some social determinant of health, but also because the system is not providing them the care needed for them to achieve their maximum goal.
Thank you. I want to follow up with the question of medical treatment that you alluded to, Dr. Correa. Dr. Rothberg, you also talked about anti-obesity medications. I'd like you to expand on this if you would, please. What's different about the medications that are available today and will be available in the next year or two compared to what we had even 3 or 5 years ago?
So thanks, Dr. Lash, for that question. Let me just start by saying that when Medicare Part D was approved, there were not the treatments that we now have available. Indeed, what's different about today is that we have several highly effective strategies, including a number of medications that are safe, appropriate, and approved for long-term use. And not only are they effective at helping people lose and, more importantly, maintain their reduced weight, but they confer benefits far beyond weight, including reduction in cardiovascular events such as heart attacks, stroke, and probably even dementia, all of which are driven by obesity. And where weight regain used to be really the norm a decade ago, it is no longer the rule when patients are provided these effective therapies.
Interesting, and I think food for thought as we think about what solutions are available to us in addressing this epidemic. Dr. Correa, as you know, obesity was declared a disease in 2013 by the American Medical Association. This is almost a decade ago. Can you talk a little bit about why you think the obesity epidemic has not been taken as seriously as other epidemics that we have faced?
Yes, it's very interesting. As you mentioned, in 2013, the American Medical Association declared obesity as an epidemic. And almost 10 years later, we are seeing the same. We are not seeing any difference. One of the reasons is that we take into consideration that obesity is something that is embedded in the person, that is a mental, that is, you can do it. And then we don't pay so much attention to that. And when we look into the physiopathology of obesity, there's many components of it. There is the biological, the social, the environmental component. And it's not that the patient don't want to lose weight. It's that there's multiple components that we need to address. And if we don't address it, then the patient will never overcome that disease, in this case, obesity. We need to treat obesity as we are concerned of diabetes. And some other comparison is that we need to treat obesity as we are treating smoking. Smoking was a big campaign during multiple years on how bad smoking was. And we are not doing that with obesity. So when we start doing this kind of things, this kind of campaigns at that federal level, at a national, at a local level, we will see some changes. It's very, again, devastating to see that 10 years ago, almost 10 years ago, we declared this as an epidemic. And this is the epidemic that just continues growing because we are not doing anything.
Thank you so much for that. I'm going to ask a related follow-up question that came from one of our attendees, and I'll start with Dr. Rothberg, but I'd like to hear what both of you have to think. My question concerns the recent cultural shift towards the normalization of obesity. While I understand the notion that all individuals, regardless of body size, deserve basic dignity and respect, there is an alarming rise in anti-science rhetoric and obesity denial in some of the more extreme camps that are in this space. How should the scientific, medical, and policy communities deal with these potentially harmful views?
Well, that is an excellent question. And I think we're all aware there's sort of a anti-scientific community around a lot of illnesses, including COVID. So obesity is not spared. And I don't think that the vast majority of those who practice in this space actually endorse those perceptions. We are very much sensitive to the stigmatization that people living with obesity face. And so we do need to be reminded that we have to treat delicately with sensitivity all individuals who are struggling with obesity and sort of tailor to their particular preferences, but not at the inclusion of saying that we are normalizing this. I do agree that there is a small but very vocal camp in those who are sort of, as you said, normalizing obesity. And I think we just need to be persistent in our education and our outreach about how to effectively manage people with obesity.
Dr. Correa?
I just want to echo Robert about education. I think that education not only to the scientific and physician community, but to the public in general and to our kids, because the kid is the future of this. And education with evidence-based and knowledge is very important, so they understand what the problem that we're facing. As Dr. Rother mentioned, we are facing a lot of misinformation and disinformation in many areas, and obesity is one of them. And we need to overcome that by being more outspoken, by being more in the radios, in the TVs, in the social media, and telling that this is affecting our population. As I mentioned, it's very similar comparing to what the smoking. When smoking started and the scientific community start saying smoking is bad, many were opposed to that. And in the 60s and 70s, you can see all the TV media that they were doing at that time saying smoking is good. You remember the type of person that smoked was a healthy male. And this is the same thing that they are doing now with the obesity. They are saying, don't worry about this. Of course, but we need, as a physician, as a scientist community, we need to be aware that we need to educate everybody.
Wonderful. Thank you for both of those. Now I'm going to ask a related question about how we actually decide who's obese and who's not. This comes from one of the other congressional offices. And it asks about a measure BMI. So how heavily is BMI utilized when scoring obesity in the data you presented? There's some concern in some area and some centers that BMI may be a biased metric and could affect how we discuss obesity. How is obesity measured, and how should we be thinking about BMI?
Another great question. So BMI is a metric. It is not the only metric, but it is an excellent, still to this day, screening a tool, because it is a measure of weight over height. So it normalizes weight to height. There are other metrics that we use, for example, waist circumference, which is another easy to get at a measure. But I will say, despite some pushback related to BMI, it does absolutely correlate well, mostly with fat accumulation. So there are some inaccuracies, people who have very muscular, for example, and it underestimates fat in a certain demographic, such as the Asian population. But for the most part, it is an excellent screening tool. Not the only, but still excellent screening tool.
Dr. Correa?
Yeah, and to add to Dr. Rothberg, I totally agree. BMI is the screening tool that we have. Of course, it's not perfect, and in medicine, we don't find 100% things that are accurate and 0%. So we are using that. I take a lot of when I read the BMIs, and mainly in the militaries, I take a lot of careful reading just the BMI, because many of them military, we talk about the obese population, but also many of them are very muscle builders, and they have a lot of muscle, and their BMI comes a little bit higher, and then they can be red in that area. But then we have to correct it. Is just to explain the amount of fat and using other techniques. But at least at this point, adjusting BMI by the different race ethnicities, we know that the Asian population have a different cutoff. So it's what we are utilizing.
Thank you very much. Also, I think it's reasonable to note that even if even that no measurement is entirely accurate, but if you use the same measurement from year to year, from decade to decade, that the increase in BMI most likely reflects an increase in obesity. Wanted to ask a little bit about the drastic increase in obesity among people of color and people in different socioeconomic groups. Dr. Correa, could you talk a little bit about that for us?
Yes, so definitely, as you saw in the presentation, there is an increase, an exponential increase when we compare race ethnicities with other race ethnicities, specifically in the people of color, specifically in Latinx, Black African American, and Native American Pacific Islander. And this is for several reasons. And I want to make a big focus on two things. One is social determinants of health. We know that this population live in areas that are food desert, that they don't have access to regularly healthy food, or the healthy food is very expensive. And the thing is, the other is that they don't have access to green, so they can go walk, do exercise, and all of this. If we look zip codes in this country where the prevalence of obesity is higher, we can see that there are industrial places that have people living in there that are from the background of people of colors. So this is very important. And the second thing that I want to emphasize is climate change that is affecting, or climate justice that is affecting those population living in those places that are very with a lot of industry around. And then they get, because of the extreme heat, they get less fresh products, and then they cannot go out and do exercise or physical activity because of this reason. So the people of color are being affected, not because there is any predisposition that we can find it, but it's because the society that we are creating on them is making them affected.
Thanks, Dr. Correa. Dr. Rothberg, I was wondering if you could spend a little time talking about obesity as a cause of other medical comorbidities, other medical illnesses, particularly diabetes, but some cancers as well. How does that connection actually happen?
So obesity is the root cause of many of those associated conditions. Particularly, let's just talk about type 2 diabetes. These are considered the twin epidemic. In fact, here's a term coined, diabesity. Diabetes is directly linked to obesity, and with the rising rates of obesity, so are the rates of diabetes climbing. But let me just say the good news is that we have evidence that with the effective strategy, some of which I talked about today, including the anti-obesity medications that really help people lose weight, diabetes can be prevented in those who are at high risk. And even in those with diagnosed diabetes, certainly those with new onset, so less than 6 years, let's say, diabetes can be reversed. So imagine, you know this, Dr. Lash, because you're an endocrinologist. how scary it is for our patients to learn. And when you say you have diabetes, they immediately think, you know, the needle, I'm going to get stuck. They think amputation, blindness, end-stage kidney disease and dialysis. But if we provide them with effective therapies, think on the other terms that how grateful they are when they lose weight and they don't have to carry that diagnosis any longer. So there are more than 13 different cancers associated with obesity. In fact, for example, endometrial cancer, the 76% of the variants of endometrial cancer is explained by obesity. And a lot of the other hormone-related cancers, even ones we don't even think about, such as thyroid cancer, which has been on the rise and is directly linked to obesity. And then, of course, the hard outcomes, like as I spoke about earlier, heart attacks, stroke. And then we have a nation that is aging and we all fear dementia, and it is also tied to that.
Great. And while you were speaking, there was a follow-up question in the chat, and it was like, I think it was more a question of methodology. How do you tease out the differences between diet, exercise, genetics, and obesity in figuring out what is the strongest link?
Well, we do understand from genetic studies that genetics plays a large role. In fact, about 70% is explained by underlying genetics. And the more sort of genetic loci that we have, the more likely we are predisposed to obesity. So we can tease out by large randomized controlled trials, when we look at diet versus exercise versus a combined approach, what is the most effective modality or modalities? And we do know that the combined approach is superior, but nevertheless, each one has a contributing factor to reducing our weight. We live in unfortunately, an obesogenic environment. And so some of our genes that were there to protect us in times of famine and predation are now a liability to us because we don't face those same environmental concerns. And so we're living in an environment that we did not anticipate, hundreds of years ago.
Great, thank you so much. Dr. Correa, you've alluded to this in a couple of your answers, but I wanted you to expand a little bit on the lack of access to obesity treatment and care, and what are some of the policy options that you would like us to be thinking about to address this issue?
Yes, so definitely the amount of new medications that we have that can treat obesity medically, it's increasing. The big issue that we have is the cost of them for the population and the access of them for the underserved population that are underinsured or uninsured. So if we look at nation Medicare or TRICARE, we can see that the only 25% or less is being covered by this nationwide insurance. If we look at the state insurance like Medicaid, there is totally a less amount, approximately between 17 and 18 states Medicaid approve the coverage of these medications. So we are dealing with a disease that is the same that we are dealing with a disease like in diabetes, in hypertension. And when we talk about diabetes and hypertension, we talk about covering those medications. But when we talk about obesity, we don't talk about covering those medications. So we need to find a regulation that cover those medications, because if we want to prevent the complication that Dr. Rothberg mentioned, we need to start treating this as a chronic disease. This is not, again, I mentioned, this is not an individual mental that you can make it. This is what I always hear. Oh, just more exercise. This is not that. This is a disease that needs treatment. And depending on the variety of treatment, from behavioral treatment to medication to surgery, we need to find a way to get coverage to all of the patients that suffer from this disease, so we can prevent the cost of the complication of the disease. We are very used to treat the complications. We need to move the needle in healthcare to prevent the complications, and prevent complication means treat the obesity as a chronic disease.
Interesting. And that idea of treating diabetes as a chronic disease fits nicely with the way we treat so many other diseases: high blood pressure, high cholesterol. You know, we don't think of these as diseases that you treat until you get to your goal and then you stop. These are chronic diseases that require chronic treatment. A couple of questions have come in about the different aspects of obesity treatment. One was talking about, one person was asking about the challenges in prescribing healthy lifestyle changes. Another was following up on your, what both of you talked about, the social determinants of health. And finally, how you balance all these with the use of newer medications. Dr. Rothberg, do you want to take a swing at that one?
Sure, be delighted to. So I am an interventionist. So that means that I treat people with obesity with lifestyle and behavioral changes. So I'm in that thick. And I'll tell you there are many barriers, and one of which is time. Physicians are tasked with so many patients whom we need to see because of productivity requirements. And so in a 15-minute encounter, there's a lot asked of us and a lot that we have to cover. And so it takes time to have a conversation about a person's weight trajectory, what their preferences may be, and then to give advice in counseling, let alone address the other aspects related not just to weight, but maybe their other comorbid health conditions. So there are time constraints and a lot of burden on the individual clinician. The other issue is billing. So although obesity has been declared a disease, we are still sort of battling with these ICD-10 codes. In fact, we have to bill often under different diagnoses. For example, diabetes or hypertension or binge eating disorder. We have to give them a different diagnosis other than obesity. We should be just tying it, the ICD code appropriately to what we're dealing with. And that just is not reimbursed. And so often we only have time to address the complications and again, not the root cause. So I think I answered that. Was there more to that question?
No, I think you did. I think you touched on all those important aspects, and the idea that it's not, it's more than just taking a shot or a pill, and it's more than just going out for a long walk. That this is a complicated disorder that requires treatment from a variety of perspectives. I also wanted to thank you for addressing the ICD-10 question. Diagnosing people with obesity is often a fraught issue all by itself, and getting accurate information into the diagnostic code world is difficult. Dr. Correa, has this come up for you at all?
Definitely. Something that come up is 15 minutes. 15 minutes to see a patient, and not only the counsel, but if we want to address this and we want to address the social determinant of health, how much time it takes to do that. So to understand the patient, where they're coming from, how can we provide the best counseling treatment for that patient takes time. And we don't have the time in a setting where you only have 15 minutes. Something that is very important is cultural competency. So understanding the community that you are serving. And when a patient from that community comes, then trying to provide them with the resources in the community and with the resources that your setting have. So this is very difficult when we are limited by the system. And by, when I say the system, is by the system not taking into account obesity as a chronic disease, going back to the prior, because we cannot have an ICD-10 code many times for any of this intervention, including behavioral and medical intervention. And we have to find a way, as Dr. Rothberg mentioned, to find another diagnosis that will help our patients. And it should not be like that. We are trained as a clinician physicians that we want to cure disease, we want to help our patients. We are not trained to follow other things that are not evidence-based.
Thanks for that, Dr. Correa. I'd like to ask both of you, what do you think obesity treatment will look like a decade from now? Dr. Rothberg, I'll let you go first.
Well, I remain optimistic that we will have more affordable medications on the rise, and that more importantly, that all people with obesity who want their obesity managed or treated will have access to those effective treatments or strategies, and that we will not be having to have this kind of congressional briefing that, we will be seeing instead of an uphill battle and rising rates in the prevalence of obesity, that we will see declining rates I feel encouraged.
That's good to hear. Dr. Correa.
I agree. I feel hopeful that we will be able to decrease the prevalence of obesity by attacking multiple layers, besides the management, also attacking the root cause, some of them that can be addressing social determinant of health in the appropriate way for the different communities. I think that the future looks great if we can make changes today. And that's, I think, the thank you to the Endocrine Society for taking the time of doing this, because it's important that all of you understand that we have a big task, and the task is to decrease obesity. And it's possible. The only thing is that all of us need to work together.
I think that's such an important point, Dr. Correa, about working together. And that's why I am just delighted to see that we have so many people in our webinar, in our briefing room today, because this is not a problem that physicians can treat by themselves. We're going to need help from policymakers and legislators to make more opportunities available for people with obesity to get the treatment that they need, both medications and non-medication based therapy. Following up on that, so if you were in today's webinar audience and you wanted more information about obesity, where would you go? Dr. Rothberg?
Well, you can go to the Endocrine Society, which has a lot of great resources for congressional staff or other people who are looking for more information about this issue. And after this briefing, we'll be sending you an educational fact sheet, which has information and some of the data that we discussed with you today. So next year, we have updated, and we will also be publishing again an obesity playbook, which is an education resource. And this will be a go-to guide for congressional staff who have questions or are looking for more information about the issue of obesity. So if you have any specific questions, though, you can also reach out to the Endocrine Society at advocacy@endocrine.org. And we will also be sharing this information with all of you after this briefing.
Great, thank you so much for that. And I just wanted, this sounds like a great time for us to wrap things up for today. On behalf of the Endocrine Society, I want to thank all of you for attending today's briefing on obesity in America. We hope you found the discussion helpful and realized the importance and urgency that all of us face in addressing this issue. The Endocrine Society encourages you to review legislation that has been introduced to address the obesity epidemic, such as the Treat and Reduce Obesity Act. We also hope you'll be able to look at other legislative opportunities as well. One in particular is the CDC's Chronic Care Center, which has been integral in improving the public's health. And this includes work being done at the CDC's Division of Nutrition, Physical Activity, and Obesity, and effective programs that have been developed, such as the High Obesity Program. After today's briefing, we'll follow up with you to share resources that we think will be of value to you, including an educational fact sheet. And we hope with the new year, you'll be on the lookout for our new obesity playbook, which we think will provide the resources that many of you will find valuable in looking at policy options to address obesity in America. So now on behalf of the Endocrine Society, our two speakers, Dr. Amy Rothberg and Dr. Ricardo Correa, and all physicians who are endocrinologists who are working so hard to treat obesity and diseases that result from it, like diabetes. Thank you for joining us, and I hope you all have a great day.